that should everybody be allowed the opportunity to have healthcare?
Yeah, people in the UK will find it quite difficult to even get their heads around criticisms of what that quote was. We do think it's a right to have healthcare and that the state should pay for it. And I think that's got to be the source of a lot of the contention and maybe the conflict between two different sides of this debate, because the guys in the US who are, saying this will be a bad thing in terms of capitalism, they're not presumably saying that they want, poor people to be given substandard healthcare or they want people to die or anything like that. I guess they're making almost like a philosophical point that they don't think it's the state's responsibility to provide healthcare to people in the same way that it is to provide an armed services and a policing force. Whereas in the UK, we're saying, healthcare, education, police, all of these things should be provided to a good level by the state.
Yeah, it is a very different view. And I think what most people are most scared about, as they look at the other systems, would be maybe the inefficiencies or the government's inability to kind of produce maybe the same quality level of care or specialist level of care.
Sure.
I'm sure you could argue that, right?
I heard one of the Republican candidates or some sort of conservative from the States basically saying, if you want state-sponsored healthcare, you've got to ask yourself, do you really want the guys from the DMV running your healthcare, your medical life?
Exactly. I think that's what the fear would be, right? The extreme inefficiency, that the quality of physicians going into practice, that healthcare wouldn't be able, government would control the healthcare and therefore it wouldn't be maybe as efficient or the quality wouldn't be as good. So maybe you could argue that. I mean, what do you think people's general feel is about the healthcare in the UK?
I've not experienced, good question, because it does come down to the quality. I've not experienced healthcare directly in the US, but I have done in the UK and in several other countries. The impression I get is that the quality of care you get on the NHS is very good. I think it's up there, both subjectively and objectively, with what you'd consider the top sort of healthcare providers in the world. I think it's got good outcome rates for most diseases. Obviously, the quality of training's very high with British medical schools and the amount of continuing education they've got to go through. I think where it falls down, and definitely the bulk of the criticism the NHS gets, isn't so much on the quality of care, although there are obvious concerns about that as well. It's mostly on the inefficiencies and the bureaucracies that you alluded to earlier. So it's things like the waiting times, it's the way in which care is delivered, and other things like that. But the actual level of care, I imagine, is roughly the same between the US and the UK, unless you're paying sort of top dollar for it in the US and you're going to like Johns Hopkins or one of these really expensive places for treatment.
Yeah. I think there's a lot of arguments. I mean, as we look at, the cost, I think if you look at the cost of, what the United States is spending, close to, like 17 or 18% of our gross domestic product, and then you look at the actual quality of the care and the price per kind of individual. While we spend a lot, you could argue that maybe the quality of care is not. I mean, it's good, but
and similar, your guys' lifespan isn't. It's roughly equivalent to what we have in the UK and in Switzerland and in other places.
I guess the other point is the value. One of the things that I think is maybe a little bit different is in the UK you've got kind of the GP, that general practitioner, which really controls, a lot of the care. And I think in the States, people kind of jump to the specialist care. But I do see kind of a paradigm shift as we look at cost and we start to analyze and, build out, as you brought up, the Obamacare or the Affordable Care Act. There's all these new models of care, like the ACOs and the bundle payments and the patient-centered medical homes, looking at how do we drive value to, the patients? How do we get better outcomes for, a lower cost? There's a shift outside of the four walls of the hospital out to the community. What is the experience in the UK? Is it, that people are mainly treated, out in the outpatient setting? How does that kind of work if I need a specialist?
So for anything that's routine care, you typically go to your GP, so your family doctor, I guess you'd call it over there. your primary care physician, basically. And they're, in a sense, the gatekeeper to specialist care. So they might think that you can be treated by them in the practice, or you can use some sort of like self-help, remedies and exercises or what have you. If they think you need a referral into a specialist at secondary care, then they can organise that. And then you're obviously under the care of the hospital at that point. There is a move to bring more hospital specialists into the community as well through clinics and home visits and that sort of thing. And then we've got emergency care, so the A&E departments where you can get more direct access for something that's quite time sensitive. A big problem that we've got at the moment, and I don't know if you've got a similar thing over there because of the way the system's set up, it can sometimes be quite difficult to get GP appointments, especially sort of out of hours, sort of in the evenings or on the weekend. So a lot of people, instead of waiting for a week or longer than that to see a GP, they'll just turn up straight to the A&E department and get referred in that way because they know they're going to get seen. And I think that's especially like, my generation sort of thing where everything's on demand. It's Netflix, it's Spotify. We don't want to wait even 2 days for something. So we'll always go to the place that will see us quicker, and that's having an effect on the costs as well.
Yeah, I think, we have this rise of and I don't know if you have it or alluded to it, but the urgent care, so how can you get access, to your point, on demand, which is, I wouldn't say a complete, emergency department, but generally, it's quick access. So you can kind of see somebody that's not your primary care, but they can kind of, I'd say, almost triage you or treat very basic things. There's the rise of telemedicine. So I think the consumers or maybe people don't like that, but the patients want more on-demand care. I think that's definitely going to be a growing trend with just, our generation and the speed at which we can do business in other arenas. So as we talk about innovation and entrepreneurship, can you talk a little bit maybe about, the NHS and some of the opportunities or maybe challenges, building projects or launching innovative ideas within the system? And what do you think maybe some of the opportunities are right now?
The NHS's relationship with innovation, I guess, will be described as complicated at best. Everyone knows that we want to be doing healthcare innovation and that kind of thing generally, but no one's really sure as to how we can do it. And there's very few people who actually want to take the risks to do it. So obviously the way our system is set up, there's not really an incentive to take the big entrepreneurial risk because you're already the dominant player in the space. There's no massive pressure for you to keep up unless there's a lot of public pressure behind it. And, for introducing certain medications, like well-publicized ones for cancer, there's sometimes pressure for those. But there's not a massive demand from the public for things like telemedicine right now. And there's no pressure that other competitors are going to come into that space. So they don't see the need to move quickly on it. I guess as a matter of fact now, some competitors are starting to come in. So we've got apps like Babylon, which does remote consultations through Android and iOS devices. But they've still got to work within the larger NHS system, and it's not really a threat that it could one day take down the NHS or reduce their revenues or their customer base. Whereas obviously in the US, you've got the opposite. If a provider doesn't keep up with the latest apps and wearable devices or whatever and look into using big data to harness value, they're just going to get overtaken by their competitors, I'm assuming.
Yeah, it's definitely, I think, very different just given the payment landscape, right? Because the United States is going through a huge transformation, with one of the largest payers, which is the government, which kind of put a stake in the sand recently and said, we're going to value-based care, which basically means that, we're going to look at, not just paying for a fee for service, so every time you go in, but more, episodes of care or managing patients in more of a risk-based contract. So thinking about, to your point, how to produce value. So I think there's an incredible excitement in the States around, the startup scene. There's the big data that you alluded to, but many companies even just, building out some of these models. There's been companies that are started, to kind of help span the population-based medicine concepts around innovative primary care where people are looking at, how can we deliver, primary care in a different way. And I think in addition to that, technology is starting to play a real force. I wouldn't say all physicians are getting that excited about adoption, but, we have the EMRs, but, there's still, I think our generation is very excited about how can we leverage technology to produce a better, more engaged patient and help our patients drive their own care.
When you
more
say
of a
your
personal.
generation, is that referring to sort of what the doctors, the managers, as well as the patients?
I think everybody's kind of using the smartphone, but I guess when I'm saying my generation, I feel like my generation of physicians is really not that the older generation aren't excited, but I think we're especially excited about some of the opportunities, with technology and taking care of our patients in a new, more innovative way, connecting with them, understanding
absolutely.
their. I don't know if the junior doctors in the UK are also pretty excited about some of
The
the
junior
tech.
doctors really are, and a surprising amount of of what I politely call the old guard as well as sort of
We
consultants.
better be
But
careful. Some of our user base, right, or
well,
listener base.
I phrased it politely. I'm pleasantly surprised by how engaged a lot of consultants are with with technology that wasn't around when they were growing up or training to do medicine, but it sometimes takes longer because they've not had that exposure to it. But a lot of them do see the value of it and incorporate it into their practice, then start advocating it. It's good to have a skeptical voice on stuff as well, because sometimes we can get a bit carried away with technology and put it into places where it's not delivering an obvious value. But no, the junior doctors are definitely really excited about it. I give talks to medical students every so often. Yeah, I'm usually expecting a lot more pushback than I actually get when I'm saying things like, IBM Watson's going to be diagnosing your patients better than you in a year from now and stuff like that. But they accept that. They like the fact that it's freeing them up from that side of the work, or it's augmenting their decision process, and it means that they can move to focus on areas of patient care where they can add more value than an algorithm can, which is great.
We'll never get away, or hopefully we'll never get away. I don't know what the future holds, but I think there's always going to be that patient-physician interaction that is that incredible special bond that many of us kind of sign up for this profession to do. That interaction and that kind of built-in trust that we as the physicians get to build, and then to your point, we augment that with technology and ways in which we can connect with our patients in a new way. Maybe not that's the only way, but a new way in which we can start engaging them. Not just kind of visit-based care where you're seeing them face to face, but throughout kind of that 365 day year journey along their care, and kind of monitor them in a way that makes sense.
I think so, yeah, and I think it's in a way, I think the technology might get to a point where it's only within like 30 or 40 years ago that medicine's got really very evidence-based and very statistical and very algorithmic. And right now we're in a sort of transition phase, I guess, between the old sort of much more simple relationship doctors and patients had in terms of the explaining and the empathy and that sort of thing. When the machines are very good at this kind of thing, about the diagnosis and all the rest of it, in a way it lets doctors focus on that one-to-one relationship with the patient and explaining concepts to them, giving them health education and advising them in a way that's aligned with the patient's interests. And that kind of wizened physician-patient relationship.
With the kind of patient relationship, the NHS, do you feel like you're able to spend, I guess maybe the other argument with more a single system or one system, do you feel like you're able to spend the amount of time that you want? I think it's even a constant struggle in the States to look at ways in which a lot of us feel fairly rushed. The appointment times are getting shorter.
Well, what's a primary care appointment time in the States? We've got about 10 minutes here.
I think you're not far off. In a busy practice, if you're seeing 30 or 40 patients, it could be 10, 15 minutes. And then you've got the nurse practitioners or the physician extenders that maybe you're working with. And I wonder, in kind of a single payer system, if that becomes easier or becomes harder to kind of work together just as a single unit or team, or people feel that would be a fear, that because there are options here in the States where you can get concierge medicine, so you can pay maybe a significant fee, or even I'm seeing a trend or a rise in what's termed direct primary care, where I see people paying $50 or $100 based on their age, and they're able to see or interact with a primary care doctor almost 24/7. Would
Minute Clinic be an example of that?
So Minute Clinic would be more of an example of kind of an urgent care, quick access. This would be,
right.
You sign up with your GP, right? And that GP says to you, James, you pay me $100 a month or, £100 a month. And
they're on retainer.
On a retainer, but you can see me or interact with me as much as you want. You can shoot me a text message. I can do a video chat.
That's a really cool idea, actually.
And that's a big, when I look at, some of the major innovations here, I see that as a huge innovation in terms of, I think there's many sides of people here that don't even agree with insurance. And direct primary care says, you pay me a fee, you come in as much as you want, let me interact with you. They're seeing insurance more in terms of, large risk, right? The heart attack, the big acute events. Primary care is more kind of maybe the way you guys view it, which is it's a right. Everybody should have it. You should see me as much as you want. I don't know what you think about that.
Sorry, there's a lot of points there. I'm just trying to structure something. First of all, that does sound like a really good idea. I think everyone would want more time with the doctors. I think 10 minutes is probably a bit pushed. I think a lot of people do feel it's a bit rushed. It sort of works in the system that we've got. The problem, we've not got enough appointments. That more GPs would probably be a good thing for the UK. I think the real strength of that system is I know that when I'm speaking to a GP, you've not got much of a systemic bias in there. So I know that when a GP will happily tell someone in the UK that they don't need an operation, for example. There's no incentive for the GP to tell someone they need an operation unless they really need it. Whereas I think, unless I'm really wrong, in the States, there are incentives in place that hospitals get reimbursed more for doing procedures. Therefore, if you injure your knee, you're not just going to get an X-ray, you're going to get an X-ray, an MRI, and a CT scan. If you might need knee surgery, you're going to have knee surgery. And, it leads to more costs to the patient. It leads to people having surgeries where the risk-benefit ratio is in a grey area. I don't know, would you agree with that, or am I listening to too much propaganda?
So I think you're talking mainly about the fee-for-service system, which, definitely value doing more, hopefully doing more appropriately. You might be able to argue that. I think as we shift, our incentives, I think this brings up a great point. As we shift to more maybe value-based care, if you have arthritis in your knee, right, and you're 85 or 90, should we do the operation or shouldn't we do the operation? I think when you move to more value and looking at, what patients really need, the orthopedic surgeon, in more of a value-based model would be more incentivized about, what can I help the patient with versus doing
absolutely.
The operation, right?
And we have targets here, to be fair. I think they're probably less strong than yours. They're more like quality targets to meet in terms of how many of your patients are diagnosed with a certain thing and how many are on treatment. So I think a bit of those bad incentives does creep in that way. It's a little bit purer in the UK in terms of the advice you get.
I think a lot is driven, both on the innovation side as well as I think some of the largest differences is on the payment side, because I think if you understand where the dollars are going, that oftentimes kind of brings up opportunities or, with new shifts in how payment is done. I think it completely changes the game, right?
Yeah. I mean, you're setting up the rules of the game, and that's going to fundamentally affect how people play that game, right? So I guess that we've sorted it in the sense of the NHS, because it is an arm of the state essentially, and its mission is to increase healthcare for people. We want to reduce costs so that we can treat the most amount of people. We've got an absolute incentive to find coronary heart disease very, very early on, even into the sort of public education of young people sort of stage, before it gets to a point where you're needing surgical intervention for it. And it sounds to me like with this move from fee-for-service to value-based medicine, that's what you guys are trying to implement now, right? So hospitals are incentivized not to do surgery, but to go back in time almost and prevent that surgery from needing to happen.
Yeah, I think you're right. And I think, because there's so many different, ways in which people get paid. I mean, it's the hospitals, it's the physicians, it's the payer. I think we are moving away from, doing more and thinking about how to produce good quality, lower cost, and produce value. The rules are changing, and so therefore might be one of the most exciting opportunities, especially those people listening both in the UK, to think about some of the opportunities, globally, especially in the States, maybe some of the things that we're doing, and maybe even applying some of the, thought process and some of the understanding about, how to, some of the work that you guys have done to really drive some of our innovation. that would be a cool opportunity.
Yeah, that'd be a fascinating exchange of ideas. In part, I guess it's what we're doing now. I think we could learn a lot about the way that you guys incorporate your innovation. I mean, it's the innovation you guys do is I think is really exciting. I agree with you, and in a lot of ways ahead of what we're doing here, because you've got those market incentives in place. And I think we wouldn't want to move to more of a market system, but we would want to see how we can take some of the components of that and internalize it into the NHS. So things like, I don't know, what do you guys do to encourage innovation? I'm guessing there's a lot of accelerators and funding going into that space.
There's a lot of accelerators. There's a lot of hackathons. A lot of what I focus on and look at is a lot of physician innovation. I think there's a tremendous amount of physicians kind of stepping out of the clinical roles and looking at, putting a new hat on and driving innovation.
It seems like that's more of an accepted idea in the States. If someone said they're a physician entrepreneur in the States, will people sort of double take at that? Or is that something people are used to?
I think it's a growing breed. I think I'm seeing a lot more physicians becoming open to the idea that, they can play a different role in healthcare and drive innovation. The reason that is because the game is changing. And because of that, I think a lot of physicians want to kind of lead the charge versus having, I know on the first episode we talked about top down. I think physicians are the front level, we understand, what needs to get done. And so I'm a big proponent of physicians kind of understanding, the new incentives, understanding where the market's going and thinking about where that puck's going and being a part of the innovation and driving it. And I hope to see many more, taking a different journey.
That's interesting. I don't know, my idea of Americans in general is, and no, it's not offensive, although there are offensive ones as well. No, you guys are very entrepreneurial just in general, I think, and it's part of your guys' mythology. It's like the American dream and not, all that sort of stuff. It's people, what do you call it? They really value the small businessman or the self-made millionaire. So it makes a lot of sense that part of the culture of physicians is also to be taking the charge and driving these innovations and making their own enterprises out of it.
Yeah.
Whereas in the UK, we're all sort of repressed and we talk about ourselves.
Exactly. It's I mean, I don't know if is it looked down upon, this whole concept of physician entrepreneurship in the UK? Do you see that the physician business guy is not an innovator but somebody that is trying to capitalize on a so-called right?
That definitely can be yes, that can be an aspect of it. I think less so recently, and it depends on how you explain it. Private practice, for example, is not universally, but often a little bit looked down upon, especially amongst NHS staff. So if you say you're going to leave the NHS and go work in private practice, there's a little bit of a feeling sometimes that you've maybe betrayed the NHS in a way, because you're sort of like, you're selling out, you've been trained by the NHS and you've been doing this sort of public healthcare system where rich and poor can attend, and the salary's not amazing, but that's sort of part of what you're doing and you're in the trenches with these people. Obviously, if you move out for a higher salary, it just creates that a little bit of conflict sometimes. When I say I'm a medical entrepreneur, I think it's different because of the associations of the word entrepreneur is generally less associated with money grabbing and huge salaries or whatever, and it's more about innovation and delivering value, and people attribute it more to people like Richard Branson and the Silicon Valley guys. So it's more of an exciting thing rather than like this fat cat corporate thing.
Yeah, exactly. And I think in the States, you brought up a lot of points. I think we're all about the American dream, or some physicians, I will say it's a new breed of physician, looking at some of the opportunities and how they can play in the game. Should we talk about the Ask Doctorpreneurs section?
Yeah, go. We've clearly sorted the difference between US and UK.
We've solved the US-UK problem. Yeah, I think we'll have to have a second discussion for sure. I think we just scratched the surface, and
I think it'll end up being a recurring topic. I'm pretty sure. It was interesting to hear your side of the US anyway.
Yeah, exactly. And so one of the questions, and I don't know if you get this a lot, I think it's one of the hot topics, and I don't have an MBA, and I see a lot of physicians or MD MBAs kind of coming out. Some will go into innovation or management later, but very few just kind of out of the gate become entrepreneurs. The question from kind of the community was that, should I get an MBA? How do I kind of get involved in the business world? What is your experience?
So MBA, I should just explain for people, is the Masters in Business Administration. So it's a well sought after professional qualification if you're wanting to go into business and corporate tiers and that sort of thing. It's not something I've heard of much in the UK. I know one clinical entrepreneur who did an MBA, but I don't know anyone else. And I know quite a few people who've gone down the business route. To me personally, I don't know how relevant it is for the startup scene and for entrepreneurship in general and setting up a digital business. I think it's probably more geared towards, large corporate roles and consultancy and that sort of thing. I think a lot of the things you need to learn about running your own business, there's only one way to do it, and that's starting your own business. Other than that, there's fantastic resources and communities online now. The network is something that an MBA can help you with, but there's other ways you can get that from. So I'd be tempted to say, I personally don't have any plans to go for one. I wouldn't necessarily advise it for people unless there was a specific reason why they needed it, like for a particular job, or they were working in an industry which had particularly high regard for it. But that's just my 2 cents. What about you?
So I kind of agree. So I've always viewed it as like a nice to have, but not a must have. I think it does give you, especially in some of the deeper finance roles, or if you're going to really do, a lot of valuations and kind of maybe join as a venture capital firm, or to your point, a consulting group. I see many MD MBAs kind of join those roles that are very, require a lot of finance and a lot of kind of number crunching. The other, role that I see is, people that are looking more for kind of administration or leadership roles in larger corporations. But, some of the best entrepreneurs that I've met, both in and outside of healthcare, are kind of just learned it as you go.
Yeah, absolutely. And the ones who are these amazing guys who do have an MBA, I'm fairly confident it's not the MBA that sort of made them like that.
Exactly. They would have been successful either way, is my assumption. MBA, no MBA.
Well, the generation of entrepreneurs coming up now, the best ones don't have a degree at all. They've dropped out of things famously. Did you read that article? Officially now, Stanford dropouts have a higher average salary than people who've completed a degree at Stanford.
That's scary. Luckily, we both didn't go to Stanford, right? So we still have potential to do well, I guess, right? Or better than the folks that actually got the degree from there.
To be fair, I think it's massively offset by Steve Jobs' wealth. But yeah, basically, I guess we're saying it's, if you've got one or you're already going for one, it's probably going to be helpful in some ways and it's going to open some doors for you, but not necessarily worth committing 2 years of your life to when you could spend that 2 years getting experience in a different way.
Exactly. You kind of have to weigh up what's the return on investment, both from a time and money standpoint. Can you build a contact and network base without it? I think absolutely. Clinic of Greatness, this is kind of our weekly topic. One of the things that I thought we'd bring up, for kind of our daily tip, just momentum. Last week we kind of talked about just doing it and the Nike slogan, but that's the getting started part. But I think the hard part is the consistency of daily action and daily movement and, just making daily progress. What do you think, James?
Yeah, that's a great point, actually. For those who don't know, my roles with my own company have changed massively over the last 18 months. So I've gone from being the main one of the main developers on the platform from a technical standpoint to doing more of the CEO role and the networking and basically about getting momentum behind the product. And the biggest way that's changed, I've had to change my work ethic, is development you can do in massive batches. So you can buy some Red Bull and do a sort of 24-hour stint and just get a lot of work done. It's awesome. But this kind of thing, you can't really do like that. You've got to do sort of half an hour here and there, a few hours each day, and just keep things going, batting emails along to people and making sure that you're on this trend towards greatness, I guess. So you've got to plan out your time and just make sure that you're, as you said, consistently working on it.
Yeah, exactly. I think the biggest point is consistency. As long as, a lot of the entrepreneurs I've studied come up with a few things that, have to get done every day, for each of the businesses. And I think that's one of the biggest keys. It's that daily step, the daily piece. So
I should read more of those, but I always avoid it because I know that when I click on it, it's going to say you need to wake up at 4 a.m. and go to the gym. I don't want to do that.
I think you're a night owl, so I think we're good. As long as you keep working late, you can get things going, and I think it's just about the daily movement, just keeping things moving.
Definitely.
So James, it's been an honor as always on the Doctorpreneur podcast. Thanks so much for
great speaking with you.
I think we'll still be debating the UK-US rivalry throughout the podcast over the coming weeks.
You realise that the NHS is better. Thanks for listening, everyone. Greg, obviously, thanks for coming on. Looking forward to the next episode where we're going to be talking about, is it telemedicine, Greg?
Yeah, we're going to talk about the future of the doctor visit. Hope everybody leaves some comments. We want to spark some comments.
Let us know what you'd like us to answer in the Ask Doctorpreneurs section. If you enjoy the podcast, just let us know what you think, how we can improve it, and of course, share it with your friends.
Thanks, guys.
Thank you.
From Greg and James, thanks for listening. We'll be back next week. In the meantime, remember to subscribe to the show and check out www.doctorpreneurs.com for more.